Welcome to the Deep Dive, the show where we turn complex research into the actionable knowledge you need for true professional mastery. Today, we are undertaking a critical and, well, pretty dense deep dive into modern surgical physiology. Specifically, we're looking at the anesthetic challenges imposed by the real revolution of laparoscopic surgery. When you look back over the last 35 years or so, this technology is arguably the single biggest transformation in surgical technique. It's huge. We've moved decisively away from those big open laparotomy incisions toward minimally invasive approaches. And it's across the board: gynecology, urology, general surgery.
Yeah.
Absolutely. The benefits are clear, right? Shorter hospital stays, less pain, faster return to function. It's really been a complete game changer for patients.
It is, undeniably. But, the clinical challenge this shift presents for us, for anesthesia providers, it's a significant paradox. While it's clearly better for the patient long-term, this move to minimally invasive techniques, it simultaneously creates these acute, profound, and frankly, unique physiological stressors. And those are the things we have to manage, in real time.
Right. And those stressors, they really define our mission for this deep dive. We need to go beyond just the basics. We have to master the complexities created by, say, the steep positioning sometimes needed, like Trendelenburg, and maybe most importantly, the creation of the pneumoperitoneum itself. We need to understand not just that the physiology changes, but the specific mechanisms involved. And critically, how those mechanisms interact with the patient's own health, their comorbidities.
Absolutely. To truly master this stuff, you have to recognize the unique physiological signature of this procedure. And it's interesting for context, this idea feels really recent, but it's actually deceptively old. The sources, they actually take us back to 1901, George Kelling's initial attempts at what he called celioscopy. He was basically trying to figure out the physiological effect of putting gas into the abdomen.
Wow, 1901. So he was looking at things like how pneumoperitoneum affected intra-abdominal bleeding, maybe from like an ectopic pregnancy.
Exactly, that kind of thing. But the concept just didn't take off. It languished for nearly 70 years.
What held it back for so long? Just the tech wasn't there.
Fundamentally, it failed because the technology just wasn't safe enough. Simple as that. The complication rates were terrifyingly high, often because of the blind entry, causing massive vascular injury, bowel perforations, accidental cautery burns. The technology really needed a major leap forward to get past those initial entry risks.
Yeah, so 1901 was the concept, but the real groundwork, the enabling tech, that came much later, 70s and 80s.
That's right. Safety really hinged on two major developments. First was the open-entry Hassentrocar back in 1971. That gave surgeons a safer, more visible way into the abdomen.
Yeah.
But the real accelerator, the thing that changed everything, was videoscopic imaging in the mid-80s. Suddenly, the surgeon could actually see what they were doing inside.
Right. Seeing makes all the difference. And the proof of concept, the one that really launched this whole revolution worldwide, that was Philip Moray's first video lap cholecystectomy in '88.
Precisely. That procedure demonstrated the huge benefits low invasiveness combined with good visualization. And from that moment, honestly, the technique just exploded globally, applied to everything from prostatectomies and hysterectomies to really complex bariatric cases.
Okay, so let's unpack the core technique now. Section 2 in our dive is about creating the pneumoperitoneum. We define it simply as putting gas in under controlled pressure to make space to work and see. But the thing we really need to focus on, you're saying, are the risks inherent in just that initial setup phase.
This is such a critical point. That initial entry, just establishing the pneumoperitoneum, it's responsible for a huge proportion of all complications. This is often, genuinely, the highest stakes moment in the entire procedure.
How high are the stakes? Let's look at the actual data, the hard numbers on these entry risks.
Yeah, the data is pretty sobering. Severe vascular injury hitting a major blood vessel is the leading cause of both morbidity and mortality. And the risk range is wide, reported between 0.1 and maybe 6.4 injuries per 1,000 procedures. That's a big range, but even the low end is significant. Bowel injury is the second leading cause. That occurs in roughly 0.4 cases per 1,000. Again, not trivial stuff. These aren't minor hiccups.
When you break down where those injuries happen, distribution-wise, where's the highest risk concentrated?
It's right at the beginning, at the umbilical puncture site. That's the most hazardous moment. We see a split. About 33% of injuries happen with that initial blind placement of the varus needle, and then a full 50% happen when the main umbilical trocar is placed right after the needle.
Wow, so most of it is right there at the start.
Exactly. Only about 17% occur with the additional trocars that are usually placed later, under much better visualization. This risk profile immediately tells you how important the choice of entry technique is.
Okay, let's detail those entry methods then. Starting with the closed technique. It's the most common, right?
Yeah.
But also the blindest.
Yeah, the closed technique uses that spring-loaded varus needle, typically inserted blindly right through the thinnest part of the abdominal wall, usually infra or intraumbilically. And because you're going in blind, confirming you're actually in the abdominal cavity safely is paramount.
How do you confirm?
We rely on a hard number here. An intra-abdominal pressure, or IAP, reading of 10 millimeters of mercury or less. That reliably indicates correct placement, and you can start insufflating the gas safely.
Okay, 10 millimeter Hg or less. What if you don't get that reading? Or the surgeon is just having trouble getting into the cavity?
You have to be really rigid about the limits here. The clinical evidence is clear. The risk of injury goes up significantly with every single failed attempt, so the recommendation is unambiguous. After 2, maybe 3 failed attempts at that site, you must immediately abandon the closed technique there.
Right.
You need to switch to an alternative technique or maybe a different entry point altogether. Just persisting blindly is asking for trouble.
Which brings us neatly to the alternative.
Yeah.
The open, or Hassan, technique, developed specifically to counteract that initial blindness.
Exactly. The Hassan technique from 1971 is an attempt to mitigate those blind entry risks. The surgeon makes a small, maybe 1 to 2.5 millimeter midline vertical cut. Then they meticulously separate the tissue layers under direct vision.
Okay.
Then they place a blunt trocar, again seeing exactly where it's going, and then they suture it in place. The theoretical benefit is obvious. You minimize the chance of hitting bowel or major vessels because you see every single layer you go through.
Makes sense. So why do surgeons still choose the blind technique so often if the open method is, theoretically at least, safer? And how do they decide which one to use?
Yeah, it's a good question. The choice still remains largely surgeon-dependent. It often comes down to their training, their experience, maybe even institutional habit. However, we do have specific clinical guidance for patients who are at a clearly heightened risk.
Right.
Patients who are either extremely thin or morbidly obese, where, the distance from the skin to the underlying vessels is really unpredictable. Or patients who've had previous abdominal surgeries and likely have adhesions, scar tissue. They're at a greatly increased risk of injury right at that umbilical entry point.
So for those high-risk individuals, what are the recommended alternatives?
They often benefit from using the open Hassan technique or sometimes using a completely different entry point, like the left upper quadrant, what's known as Palmer's point. But it's really crucial to be aware of this. A major Cochrane review analyzing thousands of patients actually showed only limited differences in the rates of major vascular or visceral injury between the closed and open techniques.
Oh, interesting. So the theory doesn't perfectly match the large-scale data.
Kind of. The open technique did show some evidence of causing fewer omental perforations, which is less serious. But the difference in catastrophic injuries, the really bad ones, was minor. It really underscores that the surgeon's skill and careful execution probably matter more than the specific technique choice in most average patients.
That's a really subtle but important piece of data for anyone looking at, say, hospital protocols. Okay, let's move past the entry phase now and get into section 3, the physiological consequences of the gas itself. We primarily use carbon dioxide, CO2. But what makes it the sort of ideal candidate gas? What are we looking for?
Well, ideally, we want a gas that's inexpensive, colorless, non-flammable, non-explosive. Importantly, easily removed by the body and non-toxic. CO2 basically ticks most of those boxes. But its crucial advantage, the real reason we use it, is safety from gas embolism.
Oh, okay.
CO2 is highly soluble in blood. It dissolves very quickly and is rapidly breathed off by the lungs. So, if a small amount accidentally gets into the vascular system, the risk of a life-threatening gas embolism is minimal compared to using, say, helium or just room air, which are much less soluble.
But it comes at a cost, right? Which is the physiological burden of the body actually absorbing all that CO2.
Precisely. CO2 is absolutely not physiologically inert. Using it forces us to deal with the consequences, mainly hypercarbia, high CO2 levels, and the resulting acidosis. Other gases have been looked at, nitrous oxide, N2O, helium, argon, but N2O supports combustion, so you can't use it with cautery.
Right, dangerous.
And highly insoluble gases like helium or argon, they introduce absolutely catastrophic risks if an embolism occurs because the body just can't get rid of them quickly. There's no strong evidence they improve outcomes anyway.
So we stick with CO2 and we manage the fallout. Let's talk about the dynamic complexity of that physiological response. It's not just the gas itself, is it? It's a whole mix of factors.
Yeah, it's a really dynamic interplay of both physical and chemical stressors. The magnitude of the body's response depends heavily on, first, the absolute degree of intra-abdominal pressure, the IAP. Is it low, like 12 millimeter Hg, or high, like 20? That matters hugely. Then, how long does the surgery last? What's the patient's physical position, especially that steep Trendelenburg needed for pelvic cases? And critically, you have to factor in the patient's age, their volume status, are they dehydrated, and any pre-existing cardiopulmonary disease. All these variables interact constantly to produce a highly individualized and often quite unpredictable hemodynamic state throughout the surgery.
Okay, let's dive into our system-specific deep dive now. Section 4, beginning with the cardiovascular effects, that big hemodynamic shift. What's the standard sort of unavoidable response we see pretty much every time that gas goes in?
Well, the consistent responses, and these happen even at moderate pressures, say around 12 millimeter Hg, are pretty uniform increases in mean arterial pressure, MAP, systemic vascular resistance, SVR, and usually heart rate as well.
Why does that happen?
It happens primarily because the pressurized abdomen acts like a tight binder. It mechanically compresses all the intra-abdominal blood vessels, especially the big ones like the aorta and vena cava.
So the heart is suddenly pumping against a much higher resistance, a higher afterload. Is there a chemical component driving this too, beyond just the squeeze?
Yes, absolutely. That mechanical compression triggers a strong neuroendocrine response. The body perceives this mechanical stress and the pressure increase, and it reacts by releasing potent hormones like vasopressin and renin. These hormones cause widespread peripheral vasoconstriction, tightening up blood vessels everywhere else. And that further sustains the increase in SVR and MAP. This happens whether the pressure is relatively low or quite high.
We also hear about a vagal response sometimes being triggered, often manifesting as a sudden, scary drop in heart rate, bradycardia, early on.
Yes, that definitely happens. The rapid stretch of the peritoneum as the gas first goes in can directly activate vaguely mediated stretch receptors. This triggers an immediate parasympathetic surge leading to bradycardia, and sometimes it can be severe enough to cause hemodynamic instability, like hypotension.
What do you do if that happens?
Well, the immediate treatment is just to temporarily release the pneumoperitoneum, let the pressure off. That usually resolves it quickly. To help prevent it, we try to keep the IAP under 16 millimeter Hg if possible, especially during the initial insufflation phase. And if necessary, particularly in susceptible patients, we might administer anticholinergics like glycopyrrolate or atropine beforehand.
Now, preload is where things get a bit confusing, isn't it? Reports on central venous pressure, CVP, seem kind of mixed. Why is it so hard to get a clear picture of the filling pressures?
Yeah, the confusion arises because we're balancing these conflicting forces. On one hand, the pneumoperitoneum mechanically squeezes the vena cava, impeding venous return from the lower body. That should reduce CVP, right?
Less blood coming back.
But the patient's position often completely overrides this effect.
And the dominant positional factor we keep mentioning is Trendelenburg, head down.
Precisely. Steep Trendelenburg position significantly increases CVP. It basically uses gravity to facilitate venous return from the upper body and pushes blood hydrostatically back towards the chest.
Okay.
Conversely, if you put the patient in reverse Trendelenburg, head-up position, that drastically reduces cardiac preload and cardiac index. This can lead to really rapid hypertension, especially if the patient is even slightly volume depleted to begin with. You absolutely have to treat the position, not just focus on the abdominal pressure number.
Got it. Okay, focusing on the final critical metrics. Stroke volume, SV, and cardiac output, CO. What happens there?
Stroke volume almost uniformly decreases across the board. This is primarily mechanical again. It's driven by that increased intrathoracic pressure effectively squeezing the vena cava and impeding venous return. Less blood coming in means less blood pumped out per beat.
Makes sense. And cardiac output?
Cardiac output becomes variable. It depends on the balance. If the heart can successfully compensate for that reduced stroke volume by increasing the heart rate and maybe gets a boost from Trendelenburg positioning, improving venous return, then CO can be maintained. However, documented reductions of 30% to 40% in cardiac output are actually quite common, even in otherwise healthy ASA 1 or 2 patients.
Wow. So this combination, a dramatically increased afterload, the heart working harder, and potentially a significant drop in output that must put the heart under incredible strain.
It absolutely does, and the sources point to a particularly concerning sign of potential ventricular instability. The pneumoperitoneum consistently prolongs QT dispersion, or QTD.
What does that mean, QT dispersion?
Prolonged QTD reflects increased heterogeneity, or variability, in the timing of ventricular repolarization when the heart muscle cells reset after beating. It signals heightened ventricular instability and a greater underlying risk for arrhythmias, like VT or VF.
That sounds worrying.
It is concerning, especially because we know the pneumoperitoneum itself induces a significant sympathetic surge, increases myocardial workload. It makes the heart acutely sensitive to any electrical abnormalities.
And this heightened risk is exactly where the elderly and the comorbid patients become our central focus, our main concern.
They are absolutely the most vulnerable population here. These patients tend to exhibit an exaggerated hemodynamic response. They often show greater increases in CVP, which can rapidly overwhelm a heart that already has diastolic dysfunction, maybe can't relax properly. And alongside that, they can experience larger decreases in MEP. Critically, those with pre-existing cardiopulmonary compromise often lack the necessary physiological reserve to meet this sudden challenge.
They just can't compensate.
Exactly. They struggle to increase their myocardial contractility enough to pump effectively against that sudden, massive increase in SVR, the afterload. And this scenario often leads directly to acute cardiac failure right when the gas goes in.
Scary stuff. But we do have mitigation strategies, right? Things we can do to help the general population tolerate this stress better.
Absolutely. The primary mitigation strategy is ensuring adequate fluid loading beforehand. Making sure the patient isn't hypovolemic is key. And then augmenting venous return through external measures, like sequential compression stockings on the legs. Studies have clearly demonstrated a benefit here. Patients who received these kinds of therapies saw their drop in cardiac output limited to only about 20%, compared to a much more precipitous 50% drop in control groups who didn't get that focused mitigation.
Okay, that moves us logically to the respiratory system.
Oh.
So the heart is being squeezed by the pressure, and the lungs are being actively crushed from below. Let's look at the mechanical impairment first, which is immediate.
Yeah, the mechanical effects are unavoidable and pretty dramatic. That increased IAP forces the diaphragm significantly cephalid upwards towards the head. This causes a major functional decrease in basically all lung volumes. Functional residual capacity, FRC, which is the air left after normal breathing, forced vital capacity, FVC, and FEV1.
So the lungs just have less room.
Exactly.
Yeah.
And that diaphragmatic shift physically pushes on the base of the lungs, causing widespread collapse in the dependent regions, the parts lowest down. This leads to profound atelectasis. Pulmonary compliance, basically, the lungs' stretchiness or ability to inflate can be reduced by as much as 43% in a patient just lying supine. It makes ventilation much harder.
And then layered on top of the mechanical crush is the chemical side, the direct result of using CO2.
Correct. That CO2 gas gets absorbed across the huge surface area of the peritoneal serosa, diffusing directly into the systemic circulation. This absorption inevitably causes hypercarbia, an increase in the arterial CO2 level, PaCO2, and the end-tidal CO2 reading, ETCO2, and that leads directly to a subsequent respiratory acidosis. It's crucial to remember this is respiratory acidosis, not metabolic. It's driven purely by the elevation of PCO2, not by things like lactate or keto acids building up systemically.
We noted earlier there seems to be a ceiling effect to this absorption, which is maybe helpful for planning our management.
Yes, that's right. The data suggests the maximum rate of CO2 absorption seems to occur at an IAP of around 10 millimolar or 10 millimeter Hg. And importantly, the arterial PaCO2 levels typically plateau. They stop rising significantly, approximately 40 minutes after the pneumoperitoneum is first established. So that first 40-minute window is when we really need to be hypervigilant about managing ventilation and CO2 levels.
Okay, so this combination of physically squashed lungs, atelectasis, and absorbed CO2 creating hypercarbia, that sets up a classic V-acute mismatch, right? Ventilation-perfusion mismatch.
It's the perfect storm, really, the double whammy for gas exchange impairment. The atelectasis, the collapsed lung units, these are areas of the lung that are still getting blood flow, perfusion, but aren't getting any air ventilation.
Right.
Now, the body tries to compensate for this automatically via something called the hypoxic pulmonary vasoconstriction, or HPV reflex. This reflex normally diverts blood flow away from those poorly ventilated, collapsed hypoxic lung units towards areas that are getting air.
But anesthesia interferes.
Exactly. The problem is that many common inhaled anesthetic agents, like the volatile gases, sevoflurane, baseflurane, actually attenuate or partially inhibit that protective HPV reflex. So if HPV is inhibited, blood continues to flow unnecessarily through those collapsed units, significantly increasing the V-QH mismatch and potentially compromising oxygenation.
There's also a subtle but potentially dangerous anatomical issue related to the endotracheal tube position that you said requires immediate attention.
Yes, that cephalid displacement of the diaphragm, pushing everything upwards. It also shifts the entire bronchial tree, including the carina, where the trachea splits upwards. This effectively shortens the distance between the tip of the endotracheal tube, ETT, and the carina,
Ah, I see.
which dramatically increases the risk of the tube migrating down into one of the main bronchi, accidental endobronchial intubation, usually the right side. If that happens, you immediately lose ventilation to the other lung, which massively compounds the atelectasis and the VQ mismatch.
So what's the recommendation?
Clinical guidelines strongly recommend reconfirming the tracheal tube position, checking the depth marking at the teeth or lips, and ensuring you hear equal bilateral breath sounds within about 10 minutes of establishing the pneumoperitoneum. This is absolutely not optional. It needs to be routine.
Okay, given these really significant mechanical and chemical challenges to breathing, how do we best manage ventilation during these cases?
Controlled mechanical ventilation is essentially mandatory to manage the CO2 load effectively. To maintain normal carbia, to keep the CO2 levels normal against that continuous absorption, studies suggest we typically need about a 20% to 30% increase in minute ventilation compared to what the patient would need without the pneumoperitoneum.
How do we achieve that increase? Higher rate or bigger breaths?
The optimal strategy seems to prioritize increasing the tidal volume, the size of each breath, rather than just cranking up the respiratory rate, though you often need to increase both. Furthermore, the mode of ventilation matters. Pressure control, PC mode, is often preferred over volume control, VC, in these situations.
Why PC over VC?
Because PC can often more effectively maintain the target arterial pH by delivering the needed volume despite changing compliance, and, importantly, usually achieves lower maximum peak airway pressures compared to VC. This helps reduce the risk of barotrauma or lung injury from excessive pressure.
We've also seen a really strong movement towards adopting formal lung protective ventilation strategies in this population, similar to what's used in critical care, not just waiting for ARDS.
Yes, this absolutely reflects current best practice and understanding of ventilator-induced lung injury. The strategy focuses on minimizing mechanical stress and strain on the lungs, even during routine surgery. This generally means adhering to low tidal volumes calculated based on predicted body weight, usually 6 to 8 millibars per kilogram. Using individualized positive end expiratory pressure, PEEP, often in the range of 6 to 8 centimeters of water pressure, to help keep alveoli open at the end of expiration.
And limiting pressures.
And ensuring plateau pressures, the pressure measured during an inspiratory hold, reflecting alveolar pressure, remains strictly below about 16 centimeters of water. Some might aim even lower. Additionally, performing recruitment maneuvers periodically, like applying a sustained high pressure, maybe 40 centimeter H2O for 40 seconds, every half hour or so, has been associated with reducing postoperative pulmonary complications by reopening collapsed alveoli.
Let's focus again on the particularly high-risk patient, someone with chronic obstructive pulmonary disease, COPD. They must be especially vulnerable here.
Uniquely vulnerable, because they already start with impaired gas exchange, often air trapping, and reduced lung compliance. One study we reviewed cited an odds ratio of something like 1 to 63 for developing postoperative complications in this group compared to patients without COPD. That's a massive increase in risk.
Wow.
They experience significantly higher levels of CO2 retention and acidosis during laparoscopy because they just can't compensate effectively. And critically for these patients, standard end tidal CO2, ETCO2 monitoring might be inaccurate, potentially dangerously so.
Why is ETCO2 less reliable in COPD patients during laparoscopy?
Because their underlying lung disease often creates a lot of dead space ventilation areas, ventilated but not perfused. This widens the normal gradient, the difference between the ETCO2 measured at the mouth and the true arterial PaCO2 in the blood. ETCO2 will often underestimate the true level of hypercarbia. So for these patients, direct measurement of arterial CO2 via blood gas analysis, ABG, or perhaps continuous transcutaneous CO2 monitoring, PTCO2, is really warranted to ensure accurate and safe ventilation management. You can't rely solely on the end tidal reading.
And just because the surgeon deflates the abdomen at the end doesn't mean the respiratory load instantly vanishes, right?
That's a crucial point, especially for post-op care planning. Because CO2 is so highly soluble in tissues, it doesn't just stay in the peritoneal cavity. It gets absorbed and stored systemically in reservoirs, particularly in skeletal muscle and even bone. This means that even after the pneumoperitoneum gas is released, the patient still has this elevated systemic CO2 load that can take hours, literally hours, to be fully excreted by the lungs.
So they're still working hard post-op.
Exactly. It persists into the PCU, increasing their immediate post-operative ventilatory requirement and potentially delaying extubation if not anticipated.
Okay, moving beyond the heart and lungs now. Let's look at the effects on the abdominal organs themselves, specifically the renal system, the kidneys, and the splanchnic circulation, which supplies the gut and liver.
Right. For the renal system, high IAP, particularly pressures of 15 millimeter Hg or greater, can definitely cause transient acute kidney injury. The pressure seems to lead to direct renal hypoperfusion, reducing blood flow to the kidneys. This in turn causes oxidative stress and evidence of acute tubular injury in some studies.
Is it just the pressure?
It's compounded by that neuroendocrine response we talked about earlier, the release of ADH, aldosterone, and renin. These hormones, along with the existing respiratory acidosis from the CO2, all drive significant renal vasoconstriction. They clamp down on the kidney's blood vessels, further diminishing renal blood flow and potentially leading to oliguria or reduced urine output during the case.
And what about the liver and the gastrointestinal tract, the splanchnic circulation? The source material noted some conflicting evidence here, which always requires careful interpretation.
Yes, this is definitely an active area of debate and ongoing research. Some evidence, often coming from animal models or perhaps human studies using quite high insufflation pressures, does show marked decreases in splanchnic and liver perfusion. This could potentially lead to intestinal ischemia, damage to the gut lining, and oxidative stress in the liver. This aligns perhaps with the clinical finding that roughly 50% of patients undergoing even routine laparoscopic cholecystectomy show some transient elevation of their liver enzymes post-procedure.
Okay, but the conflict arises when lower pressures are used, is that right?
Exactly. Other studies, specifically those using lower insufflation pressures, suggest that perfusion was either maintained or maybe even counterintuitively potentially improved compared to baseline or open surgery.
Improved? How could that happen?
Well, the hypothesis is that the local CO2 gas itself within the peritoneum might exert a direct local vasodilatory effect on the splanchnic vessels. This effect might, at lower pressures, balance out or even overcome the global decrease in perfusion caused by the external pressure. The conflicting results really underscore how sensitive this is to the specific IAP used, and probably also to the patient's overall volume status and hemodynamics.
That brings us perfectly to the immunologic implications, where the level of pressure also seems to be the determining factor. What happens to the immune response locally?
Well, the CO2 pneumoperitoneum, just by being there, seems to negatively affect the local immune response within the abdomen. It alters the concentration of various cytokines, which are key signaling molecules for inflammation. Interestingly, it has even been shown in lab studies to influence the growth rate of cultured human cancer cells, though the clinical significance of that is still debated. But here is where using low pressure seems to offer a distinct advantage, immunologically speaking.
Tell us about that low pressure finding. That seems important.
Yeah, studies that specifically compared low insufflation pressures, we're talking 6 to 8 millimeter Hg against standard pressures like 12 to 15 millimeter Hg, demonstrated statistically significant lower concentrations of key pro-inflammatory factors. Things like C-reactive protein, CRP, interleukin-1 beta, IL-1, and interleukin-6, IL-6, were all lower in the low pressure groups.
So the bottom line is lower pressure means less inflammation.
Exactly. It results in a measurably reduced postoperative inflammatory response compared to standard pressure laparoscopy.
Okay, so we have a clear, documented benefit to using low pressure reduced inflammation. But earlier, we established that high pressure, maybe up to 25 millimeter Hg, is recommended by some guidelines, like the RCOG, for a safe initial trocar entry. This seems like the core paradox we face, safety versus physiology.
That really is the central conflict we have to manage constantly during these cases. We have to recognize that the surgeon often prioritizes maximizing safety during that initial blind entry phase, which may necessitate temporary high pressure to lift the abdominal wall away from the vessels.
Right.
But the absolute minute that safety threshold for entry is met, the anesthesiologist should really be advocating for dropping down to the lowest sustainable pressure that still gives the surgeon adequate visualization and working space, maybe 8 to 10, maybe 12 millimeter Hg, especially in a fragile or comorbid patient. We need that lower pressure to minimize the ongoing inflammation and the systemic cardiorespiratory stress. We also have to keep perspective, though. Despite these local immunologic changes caused by CO2, the overall systemic inflammatory response from laparoscopy is still inherently much weaker than what you'd see after a big conventional open abdominal procedure.
Okay, let's shift focus now to Section V, looking at major complications and their management. We started by discussing how dangerous that initial entry can be, but the statistic you quoted on undiagnosed injury is truly terrifying.
It really is a shocking potential failure point in the system. The idea that 30% to even 50% of major vascular and visceral injuries might go completely undiagnosed during the operation itself, that's deeply concerning. And when a major injury like that is missed initially, the mortality rates can skyrocket up to 30% when it finally declares itself postoperatively.
Why? Why do we miss these potentially lethal events right there in the operating room when everyone is watching?
Well, delayed diagnosis happens for a couple of main reasons, typically. First, the initial signs may be unexplained hypotension, tachycardia, a gradual drop in hematocrit can easily be confused with other common perioperative events. Things like anaphylaxis, maybe an anesthetic drug effect, or even an acute cardiac issue unrelated to the surgery itself. The picture can be muddy. Second, and this is particularly relevant for bleeding, especially major venous bleeding in the retroperitoneum. The high intra-abdominal pressure from the pneumoperitoneum can actually tamponade the bleeding site. It contains the hemorrhage, masking the true extent of the blood loss until either the pressure is released at the end of the case or the patient decompensates so severely that the cause becomes obvious.
We need to reinforce that slightly counterintuitive finding regarding entry safety and pressure again. It seems critical.
It is absolutely essential to remember this nuance. While we just established that low pressure is physiologically gentler overall, guidelines like those from the Royal College of Obstetricians and Gynecologists, RCOG, and Cochrane reviews actually advocate for placing that primary trocar under temporary high pressure, maybe up to 25 millimeter Hg for just a moment.
Why high pressure for entry?
Because that high pressure maximizes the distance between the abdominal wall and the underlying great vessels, aorta, vena cava, iliacs, right at that critical moment of blind puncture, it theoretically makes that initial stab safer. So we have to manage this brief period of high pressure for entry safety before immediately dropping back down to a more physiologically tolerable maintenance pressure for the rest of the case.
Okay, let's discuss the complication that probably causes the most anxiety. Gas embolism. It's rare, thankfully, but potentially fatal when it does happen.
Yes, gas embolism occurs when blood vessels are open either from direct surgical trauma or accidental puncture during trocar placement, and the pressure inside that vessel is lower than the surrounding intra-abdominal pressure. CO2 gas then gets entrained, sucked into the venous system. It travels up through the vena cava to the right side of the heart and can potentially lodge in the pulmonary outflow tract, blocking blood flow to the lungs.
Like an airlock.
It's exactly like an airlock. This mechanical obstruction leads to acute right ventricular failure, a subsequent catastrophic decrease in cardiac output, and ultimately cardiovascular collapse if not treated instantly.
What are the absolute earliest warning signs we might pick up on the monitors?
The classic immediate clinical presentation is an acute, often precipitous drop or even outright loss of the end-tidal CO2 waveform and reading, PETCO2. This happens because the gas bubble is obstructing pulmonary blood flow, so CO2 isn't getting back to the lungs to be exhaled. This is usually accompanied by sudden, severe hypertension and hypoxia. Also, if the gas and train happen to be room air instead of CO2, maybe during open entry before insufflation, you might see a sudden spike in the end-tidal nitrogen reading if your gas analyzer measures it.
What about the classic signs we learned about, like the mill wheel murmur? Are they useful?
Well, the mill wheel murmur, that churning or splashing sound sometimes heard with a stethoscope over the precordium, is the classic textbook sign, but it's actually a very late sign. It typically only appears when massive volumes of gas, usually 2 milliled per kilogram or more, have already been entrained. By the time you hear it, the patient is likely already severely hemodynamically unstable.
Not helpful for early detection, then.
Not at all. The most sensitive diagnostic tool we have, capable of detecting emboli as small as 0.02 millimole per kilogram, is transesophageal echocardiography, TE. But obviously, T isn't routinely used in every laparoscopic case. Interestingly, some case reports also describe a phenomenon of seesawing, EtCO2 readings rapidly fluctuating up and down, sometimes preceding a massive embolism. This might reflect small intermittent tears in vessels, allowing small amounts of gas in before a major event.
Okay, if you suspect or diagnose a gas embolism, immediate coordinated action is absolutely critical. What are the key steps in management?
The treatment has to be instantaneous and involve the whole team. First, immediately halt all gas insufflation. Stop the CO2 flow. And critically, discontinue any use of nitrous oxide anesthetic, as N2O rapidly diffuses into air spaces and will expand the volume of the gas bubble, making the obstruction worse.
Okay, stop gas, stop nitrous. What next?
Second, the surgeon must immediately flood the surgical field with normal saline. This helps prevent further air or gas entrainment from any open vessels. Third, release the pneumoperitoneum completely. Let all the pressure out of the abdomen to lower the IAP below venous pressure.
Right, position change.
Fourth, position the patient rapidly into the left lateral decubitus position. This is often called the Durant maneuver. The goal is to try and trap the gas bubble in the apex of the right ventricle, allowing blood to hopefully continue flowing past it through the pulmonary artery outflow tract. Finally, if a central venous catheter, CVC, happens to be in place, attempt to aspirate the gas directly from the right atrium or ventricle through the CVC, and simultaneously provide aggressive hemodynamic support fluids, vasopressors, whatever is needed to maintain circulation.
Okay, moving on to gas migration issues that are generally less immediately fatal, but certainly more common. Subcutaneous emphysema and pneumothorax or pneumomediastinum.
Right. Subcutaneous emphysema occurs when CO2 gas tracks out of the peritoneal cavity and dissects into the subcutaneous tissues, the layer just under the skin. This often happens through small tears or rents in the fascia, perhaps around poorly sealed trocar sites, or sometimes just due to prolonged high insufflation pressures forcing gas where it shouldn't go. While most cases are clinically insignificant and just look alarming, like crepitus under the skin, severe cases can actually lead to dangerous hypercarbia as the CO2 gets absorbed systemically from the tissues, and can also decrease chest wall compliance, making ventilation difficult, and potentially causing hemodynamic instability if it tracks up into the neck and mediastinum.
Are there clear risk factors that should make us anticipate subcutaneous emphysema might develop?
Yes, several factors increase the risk. Things like having an EtCO2 that's sustained above 50 mm Hg for a long period, operative time exceeding about 200 minutes,
Yay.
using 5 or more trocar ports, and maintaining consistently high insufflation pressures throughout the case.
How do you manage it if it occurs?
Management primarily involves trying to reduce the driving force. So first, lowering the IAP if surgically feasible, definitely stopping any N2O use, as that would worsen it, and aggressively increasing the patient's minute ventilation to try and blow off the excess absorbed CO2. In rare, really severe cases where the emphysema involves the head or neck significantly, potentially compromising the airway, the patient might actually need to remain intubated postoperatively until the bulk of the gas has been reabsorbed and the swelling subsides. Pneumothorax and pneumomediastinum are similar issues of gas migrating where it shouldn't. The reported incidence is around 1.9%. Here, the gas actually enters the chest cavity, the thorax. This can happen through pre-existing congenital defects or maybe old embryonic connections between the chest and abdomen, or sometimes through direct perforation of the diaphragm or pleura during surgery.
How do you manage that?
Well, it's important to distinguish between two potential types. A pneumothorax caused directly by the CO2 gas tracking into the chest often resolves spontaneously once the insufflation is stopped, because the CO2 gets rapidly absorbed from the pleural space. However, a pneumothorax caused by barotrauma lung injury from the high airway pressures we might be using to ventilate the patient against the pneumoperitoneum, that's different. Barotrauma results from physical lung injury and almost always requires surgical decompression with a chest tube placement.
Okay, let's move into Section 6 now. Looking at specific anesthetic management strategies and some of the ongoing controversies, we can start with non-general anesthesia techniques. When might local anesthesia or just sedation be appropriate?
Yeah, these techniques can actually be highly effective for relatively minor laparoscopic cases, things like purely diagnostic laparoscopy, maybe some types of tubal ligation or extraperitoneal hernia repairs. The benefits can be substantial, potentially reduced hospital costs, often faster recovery and discharge, significantly less postoperative nausea and vomiting, PONV, and usually minimize hemodynamic changes compared to general anesthesia. The constraint is crucial, though. It absolutely requires a cooperative patient who can lie still and tolerate some discomfort, and it demands a very gentle, efficient surgical technique, usually shorter cases. Trying to combine heavy sedation with a pneumoperitoneum is actually quite risky, as it significantly predisposes the patient to hypoventilation, CO2 retention, and potentially arterial desaturation if their airway isn't secured.
What about regional anesthesia? Using spinal or epidural techniques. They offer excellent analgesia and can blunt the stress response. But in a laparoscopic context, they seem plagued by some technical challenges.
They are challenging, yeah, for two main reasons in this setting. First, to get adequate sensory blockade high enough to cover the peritoneum, which is innervated quite high up, you often need a very high sensory level from your spinal or epidural, sometimes up to T4 or even T2.
That's high.
It is. And achieving that high level inevitably results in significant sympathetic blockade, which carries a major risk of severe hypotension that can be difficult to manage, especially with the added hemodynamic stress of the pneumoperitoneum. Second, and this is probably more important practically, regional anesthesia does not reliably manage that common postoperative shoulder tip pain, STP. Studies show STP still affects somewhere between 27% and 47% of patients, even with a good regional block for the abdomen.
Right. Why does regional anesthesia fail to cover that shoulder pain? It seems counterintuitive if the abdomen is numb.
Yeah, it's because STP is referred visceral pain. It's caused by that residual CO2 irritating the diaphragm, which activates the phrenic nerve. The phrenic nerve originates much higher up in the neck, typically from nerve roots C3, C4, and C5. This is far higher than the sympathetic block level, like T4, you achieve with a typical spinal or epidural aimed at abdominal surgery. So the regional anesthetic simply doesn't reach high enough to block the phrenic nerve reliably, leaving the pathway for shoulder pain wide open.
Okay, so general anesthesia remains the standard for most significant laparoscopic procedures. The primary controversy here seems to be about the airway device. The classic endotracheal tube, ETT, versus laryngeal mask airway, LMA. The whole debate centers on the risk of aspiration, right?
Exactly. Traditionally, the cuffed ETT has been seen as the gold standard because it completely secures the airway below the vocal cords, theoretically preventing anything from the stomach getting into the lungs. The LMA controversy arises because we know that increased intra-abdominal pressure from the pneumoperitoneum significantly reduces what's called the barrier pressure, BRP.
Air pressure.
Yeah, BRP is basically the pressure difference between the lower esophageal sphincter, LES, the valve at the bottom of the esophagus, and the pressure inside the stomach. It's what normally prevents reflux. When the IAP goes up during laparoscopy, the gastric pressure increases, squeezing the stomach. This reduces that pressure gradient across the LES, lowering the barrier pressure and making the patient inherently more susceptible to regurgitation of stomach contents up into the pharynx, and potentially aspiration into the lungs if the airway isn't protected by an ETT.
And obese patients, they start with a lower barrier pressure baseline anyway, right?
Yeah.
Making them potentially even more susceptible.
Exactly right. Even though the pneumoperitoneum decreases BRP in pretty much all patients, the already lower baseline BRP often seen in obese patients means they are at a higher inherent risk of aspiration when using any supraglottic airway device like an LMA during laparoscopy. However, modern systematic reviews and newer LMA designs are definitely changing this traditional landscape.
Also, what's the newer data showing?
While several large systematic reviews comparing modern LMAs, especially second-generation ones, to ETTs for laparoscopic surgery actually show that the LMAs resulted in significantly less postoperative laryngospasm, less coughing on emergence, and fewer sore throats.
Okay, better side effect profile. But what about the aspiration risk?
Crucially, many of these large studies showed no significant difference in the actual rates of clinically apparent aspiration between the LMA and ETT groups, particularly for low-risk patients undergoing procedures with limited Trendelenburg and lower IAPs. This suggests that modern second-generation LMAs might be acceptable alternatives in carefully selected patients, provided the IAP is kept relatively low, example under 15 millimeter Hg. The LMA ProSeal, or similar devices with high seal pressures and a gastric drainage channel, are often preferred because they offer a higher oropharyngeal leak pressure, OLP, meaning they can handle higher airway pressures before leaking, and that gastric drain allows for continuous decompression of the stomach, actively minimizing the risk of reflux buildup.
Okay, interesting evolution there. Let's talk about the anesthetic gas itself specifically, the use of nitrous oxide, N2O. This remains highly controversial, mainly due to its two potential major downsides.
Yeah, the first big downside is postoperative nausea and vomiting, PONV. The studies here are a bit mixed, but one major trial clearly demonstrated that N2O increases both the incidence and the severity of PONV, and it seems to be in a dose-dependent manner. Patients in that trial who received high concentrations, like 70% N2O, had a statistically significantly greater incidence of nausea compared to those who received no nitrous oxide as part of their anesthetic.
Okay, so more PONV. And the second major downside is bowel distension, right? Which seems like it could directly affect the surgeon's working conditions.
Yes, this is a really complex area because the results seem to vary quite a bit depending on the type of surgery being done. For example, in laparoscopic donor nephrectomy cases, N2O was found to cause bowel distension severe enough that the surgeons actually had to halt the surgery temporarily in about 25% of the patients receiving it.
Why does it distend the bowel?
N2O diffuses very rapidly into any air-filled spaces in the body, much faster than nitrogen diffuses out. So it essentially rushes into the bowel loops, ballooning them up and potentially obscuring the surgical view. However, to show the complexity, in a different randomized controlled trial involving morbidly obese patients undergoing bariatric surgery, the surgeons were actually unable to detect any meaningful difference in bowel distension or surgical commotions between the group that got N2O and the group that didn't, even over a 90-minute period. So it might be less of an issue in some populations or procedures than others.
Fascinating. Okay, the final controversies we need to touch on involve muscle relaxation levels and the choice between total intravenous anesthesia, TIVA, and traditional inhaled volatile agents. Starting with neuromuscular blockade, is deep block, like 0 twitches on the train of 4 monitor, actually worth the potential risks?
Yeah, the hypothesis behind using deep neuromuscular blockade, typically defined as a train of 4 TOF count of 0, maybe with a post-tetanic count, PTC, of 1 or more, is that it might allow the surgeon to achieve optimal working conditions, good exposure, stable pneumoperitoneum, at lower intra-abdominal pressures. If true, this could potentially mitigate some of those negative physiological stressors we spent so much time discussing earlier.
Does the evidence support that?
Well, one meta-analysis did support this idea. It suggested that using deep block significantly improves the surgeon's assessment of surgical space conditions and, interestingly, also seemed to reduce postoperative pain scores compared to moderate block. However, this finding is actually strongly disputed by other studies. These conflicting studies often show no significant long-term benefits in overall patient outcomes or recovery times with deep block, and they raise the very significant clinical concern about the increased risk of inadequate reversal at the end of the case, potentially leading to residual neuromuscular blockade and prolonged postoperative respiratory depression or weakness, especially in high-risk or elderly patients. So the benefit versus risk calculation is still very much debated.
Okay, and the final, head-to-head. TIVA versus inhalational agents for maintenance of anesthesia. Is one clearly superior?
Based on a broad Cochrane review that specifically compared TIVA, usually propofol-based, against inhalational volatile agents used alone as the primary anesthetic, they found essentially no clear superiority for either technique when looking at major outcomes like postoperative pain scores, the overall incidence of PONV, or other significant adverse effects.
So, based on that review, the choice of the primary agent itself wasn't the main driver of benefit.
Exactly. According to that review, the real benefit of TIVA seems to emerge only when it's integrated strategically into a comprehensive multimodal approach, particularly for PONV prevention. For instance, when TIVA was specifically combined with multimodal antiemetic therapy, using several different anti-nausea drugs together, it showed a significantly higher response rate, around 90% effectiveness in preventing PONV compared to using just inhalation anesthesia or just propofol alone, which were around 63–66% effective.
Why is TIVA better in that combination?
Yeah. It's likely because propofol, the main component of TIVA, has inherent antiemetic properties itself. This synergizes powerfully with other standard antiemetic drugs acting on different receptors. Furthermore, there's also the consideration we touched on earlier. Some volatile agents are known to suppress that protective hypoxic pulmonary vasoconstriction HPV reflex more significantly than TIVA does. So TIVA might be preferable in patients where maintaining optimal V-CHUGE matching is a major concern, perhaps those with significant pre-existing lung disease.
That sets the stage perfectly for our next section, Section 7, focusing on postoperative concerns. Given that incredibly high PONV incidence you mentioned, potentially up to 72% after laparoscopy, it's really no wonder that many patients actually fear the nausea more than the pain itself.
Absolutely. PONV is a major quality of recovery issue after these procedures. The etiology, the cause, is complex. It involves the choice of anesthetic, the amount of opioids used for pain, the surgical stress response itself, maybe even irritation from the CO2. Because it's multifactorial, multimodal antiemetic therapy, meaning combining several different anti-nausea agents that work on different neurochemical receptors, like steroids, 5-HT3 antagonists, dopamine antagonists, NK1 antagonists, is now considered the absolute standard of care for moderate to high-risk patients. Prophylaxis is key.
Post-laparoscopy pain is equally complex, isn't it? We have to think about and address three quite distinct components.
That's right. The pain profile after laparoscopy is really kind of trisected. You have the incisional pain, which is typical somatic or parietal pain from the port site cuts in the skin and fascia. Then you have deep intra-abdominal pain, which is true visceral pain arising from the organs being manipulated, stretched, or dissected internally. And finally, you have that infamous shoulder pain, which is actually referred visceral pain.
And the pattern changes over time.
Crucially, yes, the pattern shifts. Generally, the deep visceral pain tends to dominate on the day of surgery itself, likely due to the organ distension and manipulation. But then, the shoulder pain often takes over and becomes the most prominent or dominant complaint on postoperative day 1.
What are the specific mechanisms driving that visceral pain and the referred shoulder pain? They seem different from typical surgical site pain.
They are different. The deep visceral pain likely results from the physical stretching and manipulation of the internal organs during the dissection. This activates specialized nociceptors, pain receptors, within the gut wall that signal via the enteric nervous system. The shoulder tip pain, STP, on the other hand, is thought to be purely chemical and mechanical in origin. That residual CO2 gas trapped under the diaphragm after the case dissolves slightly in the peritoneal fluid, forming carbonic acid. This lowers the local intraperitoneal pH, creating an acidic environment that directly irritates the sensory endings of the phrenic nerve on the surface of the diaphragm.
And because the phrenic nerves share.
Exactly. Because the phrenic nerve, innervating the diaphragm, shares common neural pathways in the spinal cord with nerves supplying the shoulder area, around C3-C5. The brain misinterprets the origin of the pain signal and perceives it as coming from the shoulder. Classic referred pain.
Given these multiple pain sources, what are the key pharmacologic strategies we should use in a multimodal analgesic approach?
Well, non-steroidal anti-inflammatory drugs, NSAIDs, are absolutely crucial. Agents like celecoxib, a COX-2 inhibitor, ketorolac, a non-selective COX inhibitor, and even acetaminophen, paracetamol, are highly synergistic with opioids. They significantly reduce the total amount of opioid needed for adequate pain control, which is important for reducing opioid side effects. For instance, short-term use of celecoxib, started preoperatively, has been clearly shown in studies to decrease postoperative pain scores, reduce opioid requirements, and improve the overall quality of recovery compared to placebo.
And dexamethasone seems like a double agent here, beneficial for both pain and nausea.
It really is the ultimate dual-action drug for this type of surgery. We primarily think of it as an extremely effective antiemetic, reducing PONV. But its potent anti-inflammatory and analgesic effects also significantly modulate the postoperative pain response. It works by inhibiting prostaglandin synthesis and reducing the release of major inflammatory cytokines.
When should it be given?
Preoperative administration of a single dose of dexamethasone, typically 4 8-milligram IV, has been shown to significantly decrease total opioid consumption for up to 48 hours after surgery, and, as mentioned, dramatically reduces PONV incidence. It's a cornerstone of enhanced recovery protocols.
What about using local anesthetics? The evidence seems a bit more mixed on exactly how and where to apply them effectively.
Yeah, the evidence is definitely more nuanced here. Simple infiltration of the surgical incisions, the port sites, with a long-acting local anesthetic like bupivacaine or ropivacaine is generally quite effective for treating the incisional parietal pain component, which can be bothersome particularly on day 2 or 3.
But what about putting it inside?
That's where it gets murky. The evidence is highly variable, often conflicting, regarding the benefit of instilling local anesthetic solution into the peritoneal cavity itself, or doing specific port site infiltration beyond just the skin. The results vary widely between studies, possibly due to issues with achieving good distribution of the anesthetic throughout the large peritoneal space, or reaching the right nerve targets. Newer techniques are emerging, like ultrasound-guided nerve blocks targeting the abdominal wall, such as the transversus abdominis plane, TAP block. These aim to block the somatic nerves supplying the abdominal wall more comprehensively. They are being explored actively, but definitive universally accepted evidence of their superior benefit, especially for the visceral pain component, remains somewhat mixed compared to simpler infiltration.
Since that shoulder tip pain often dominates post-op day one and is notoriously difficult to treat once established, what is the single most effective intervention to actually reduce its incidence or severity in the first place?
Since the pain is fundamentally caused by that residual CO2 gas irritating the diaphragm, the most effective interventions are logically those that target the elimination of that residual gas before the patient leaves the OR. This includes several things. Physical maneuvers performed by the anesthesia team at the end of the case, like performing pulmonary recruitment maneuvers, sometimes called sigh breaths, or providing extended assisted ventilation for a few minutes after deflation, can help expel gas trapped under the diaphragm. And perhaps most importantly, active aspiration of as much residual intra-abdominal gas as possible by the surgeon prior to fascial closure. Using suction under direct vision to remove pooled gas. These active gas removal strategies have been repeatedly shown in studies to significantly reduce the severity of STP measured at 24 hours postoperatively. Prevention is key here.
Okay, finally, let's look ahead briefly to Section 8 and the future trajectory of minimally invasive surgery. Robotic assistance has clearly been a huge step forward, fundamentally changing the surgeon's capability.
Yes, robotic-assisted surgery, using systems like the Da Vinci platform, represents a major technological advance within the minimally invasive world. For the patient, it often translates to procedures with even greater precision, potentially leading to decreased postoperative pain, maybe less blood loss, and shorter hospital stays for complex operations compared to standard laparoscopy. For the surgeon, the key advantages are things like improved dexterity through wristed instruments, better ergonomics, sitting comfortably at a console, and critically, the incorporation of true three-dimensional 3D stereoptic imaging. This provides far superior depth perception compared to the standard 2D flat screen view of conventional laparoscopy, which is a huge advantage for complex dissection.
And perhaps the ultimate goal, especially from our perspective in anesthesia, must be to try and eliminate our core physiological problem entirely. The need for the pneumoperitoneum itself. Tell us about gasless laparoscopy.
That really is the ultimate technological push for certain procedures to achieve minimally invasive access without the CO2. Gasless laparoscopy typically uses specialized fan-shaped retractors or other mechanical devices that are inserted to physically lift and retract the abdominal wall upwards, creating a working space without needing to insufflate any gas.
Does it work? What's the early promise?
Early studies, although still limited primarily to specific procedures like some gynecological surgeries or cholecystectomies, show tremendous promise. Compared to conventional CO2 laparoscopy, these gasless approaches have demonstrated potentially lower intraoperative blood loss, significantly decreased postoperative pain, especially shoulder pain as there's no CO2, and importantly from our discussion, evidence of less postoperative inflammation because that major CO2 stressor is completely removed from the equation. It bypasses all the physiological issues we've discussed.
Okay, to bring this incredibly detailed deep dive into final focus now in our synthesis section. What is the absolute core understanding required for true mastery of the anesthetic challenges in this highly specialized field of laparoscopic surgery?
I think mastery really demands an intimate, dynamic understanding of this unique physiological state we induce. The core challenge lies in the simultaneous management of two powerful, often opposing forces. First, there's the mechanical stress imposed by the high intra-abdominal pressure itself, compressing the heart and great vessels, physically shifting the diaphragm upwards, impeding ventilation, and dramatically increasing cardiac afterload. And alongside that, you have the ongoing chemical stress of CO2 absorption across the peritoneum, inevitably leading to hypercarbia and respiratory acidosis that must be actively managed. These factors are dangerously compounded and are increasingly common comorbid in elderly patient populations who lack the reserve to cope. So, understanding the absolute physiological limits and the critical interplay between pressure settings, the patient's fluid status, and your ventilation strategy is absolutely essential for protecting systemic perfusion, oxygenation, and lung mechanics throughout the case.
This deep dive has really exposed some fascinating and sometimes quite contradictory data points like the need for transient high pressure for safe entry versus the clear documented physiological benefits of maintaining low pressure, maybe 6 to 8 millimeter Hg, for reducing inflammation and stress. It really underscores that the pathway to mastery isn't just about knowing the isolated facts, but crucially, knowing when and how to apply them dynamically in real time, often balancing competing priorities. So given the detailed evidence we've discussed on the physiological benefits of minimizing IAP whenever possible, and the particularly high risk associated with the comorbid patient's potentially reduced cardiac reserve, consider this final provocative thought for you, the listener. What specific measurable hemodynamic trend, maybe a falling cardiac output, a rising CVP despite fluid worsening acidosis, or perhaps a critical respiratory trend, like rapidly climbing airway pressures or falling compliance, observed in a vulnerable patient under your care. What specific trigger point would immediately prompt you to actively recommend a surgical change?
Specifically, to advocate strongly for reducing the intra-abdominal pressure, even if it slightly compromises the surgical view, because that instant data-driven collaborative decision-making between anesthesia and surgery, guided by this complex physiology, is perhaps the true measure of success in genuinely minimizing the invasiveness of the procedure for that individual patient.